its members, nor KCUS TV shall be responsible for the views, opinions, or facts expressed by the panelists on this television program. Please consult your doctor.
We have orthopedics and sports injuries. We also have a lot of weekend warriors out there, and then student athletes. School's about to start. And then we have everybody that falls in the groups right in between. So today, and during this next hour, we've got doctors that are going to be dealing with common athletic injuries, how they are treated, and more importantly, for most of us, how to prevent them in the first place. This is a live program, as you know, so think of some questions you want to call in with. The live number is 881-0013. This evening's program is underwritten by Las Palmas del Sol Healthcare, and also a very special thank you to the Paul L. Foster School of Medicine for the medical students that they provide each and every month, taking in your calls and then bringing them with beautiful handwriting over to me, and that's always helpful. And also a huge thank you to the El Paso County Medical Society and all the doctors. All of us are volunteers here this evening, and they provide the show to you once, if not more, every single month. Good evening, I'm Catherine Berg, and you're watching the El Paso Physician. Good evening. Thanks again for joining us. This evening is all about orthopedics in one way, but also it's about injuries and sports injuries. We say sports injuries, but we're also going to include walking the dog around the block and, oh my gosh, I just misstepped on the curb. That's a sport. That's what I consider a sport, because I know several people that have done that and really messed up ankles and knees and all kinds of stuff. So we have Dr. Toby Natividad with us, who is specializing in orthopedic medicine, in sports medicine, and in surgery. We also have Dr. James Bean, who's been with us in the past, but it's been a while, so it's nice to see you again, doctor. Also specializing orthopedic sports medicine and surgery. And then we have Ryan Sorensen, who is an exercise physiologist. I just like that name. Are you a physical therapist? No. I'm an exercise physiologist, and that there is a difference, and I'm going to ask you to explain to our audience what that difference is. So with that being said, Dr. Natividad, you've been with us the last several times we've had some orthopedic shows, and you've always got new and interesting things to talk about. On your daily basis, for the people at home, what do you do all day, every day? You dabble in surgery, you dabble in diagnosis, you dabble in everything, so that way you can kind of give everybody the idea of what you do.
Sure. So I'm an orthopedic surgeon. I specialize in sports medicine, knee and shoulder reconstruction. Very similar to Dr. Bean. We're colleagues, and we both did an extra year fellowship in sports medicine. So that's our specialty. Probably our clinics are very similar. We both treat patients from varying ages, from young adolescents, even some children or so forth, all the way up to maybe a geriatric population. When we're talking about sports injuries, that can include anything from covering high school athletic events to we also donate our time to the UTEP minors, and we're team physicians for them. And so our week can be made up of clinic time, as well as surgery for elective surgeries, and then trauma as well for traumatic injuries.
And it's all encompassed in one. I mean, I know we had a trauma show just recently too, but you're really kind of still using, I don't want to call it basics, but when we're looking at orthopedics, and it's beautiful too that we have some of the bones and ligaments and muscles here this evening too to explain that to people. Dr. Bean, the same thing but different, because every doctor does things a little bit differently. How do you explain what you do all day, every day?
Well, if you kind of notice, I got a little more gray hair than Toby does. So as you
work harder, that's why, right?
Or worry more. As you get older, you tend to grow old with your patients too. So a lot of those sports injuries turn into degenerative problems later, and so a lot of my practice is dedicated to joint reconstruction from that standpoint. I do a fair amount of joint arthroplasty with sports medicine.
And we talked last time we had a show like this about so many people that injured themselves back in high school, haven't really done a lot of sports in the last decade, 2 or 3 decades, but now things are coming back. So I'd like to talk, and I'll specifically ask you some of those questions, because that's my aging population. I'm 51, so I feel like we're 30 years out of high school, right? And now it's like, why is my knee bothering me? I haven't done anything since I used to do, I don't know, all kinds of gymnastics back then, but it's a thing that's coming back to haunt us. As a exercise physiologist, did I say that right? Yes, an exercise physiologist. Explain to the audience how that's different from a physical therapist and what you do all day, every day.
That's a good question. I apply the scientific principles of exercise in the clinical setting. So essentially I'm able to take aspects of research and the studies of exercise and apply it for the populations of individuals who have diseases or individuals who have types of injuries or other types of degenerative issues that they're dealing with, and address that in a clinical format or otherwise in an athletic format.
Very nicely said, too. And it's something, too, that we don't often talk about different diseases in this area. We're going to talk about sports injuries, but also people playing sports that may have a condition before, starting in the 5th grade or 6th grade, or even, gosh, these days, before kindergarten, people out there playing football. It's a little scary. Dr. Natividad, let's start with you in just the most common sports injuries that you see, and then from there we're going to build the show, if that makes sense.
Sure. So I'd say in general, probably our most common injuries would include really the lower extremities, the knee, the ankle, and then if we're looking at the upper extremity, the shoulder, maybe the wrist and so forth, repetitive overuse injuries. And this can span from what you were mentioning earlier, our young generation, kindergarten. Kids now are in club sports year-round, so we see a lot of overuse injuries as well. Especially when they're playing the same sport year-round, they then develop a certain set of skills, and we now know that it's actually better for them to cross-train or play several different types of sports so that they give other body parts rest during the year. So in general, a lot of knee and ankle injuries, from sprains to torn ligaments to maybe tendon injuries as well.
I'm going to try to transition a little bit. I know that we're talking with Dr. Bean about things that happen later on in life, but as you were talking about kids, and I brought that up myself, is the growth plate. And I remember being fascinated the last time that we talked a little bit about that growth plate in children. So I'm going to throw it to you. If you want to throw it back to Dr. Natividad, I completely understand. But explain to the parents, the grandparents out there that do not realize that at the age of 7 to maybe 12 or so, there's some growth plate stuff going on that doesn't really solidify until they're in their late teens. Talk a little bit about that so we've got a base there.
It's a big factor in children, of course. They have a cartilaginous plate that's adding length to the long bones and other ways too, in different special applications, but primarily if you think of it, they add length to the long bones, and injuries can occur to those that can cause interruption of the growth. It can actually cause acceleration of growth in some cases, and so that can lead to deformities that need to be addressed and corrected. So yes, childhood injuries are a bit different, fractures in particular for the growth plate, and a lot of times have to be addressed specifically for the specific growth plate or body part.
And on that note, and I don't want to spend too much time on that because it is sports injury, so I do want to talk about that back to school time. The treatment then, so sometimes if a person, and maybe throw an age out there, say up to the age of más y menos, how old is that growth plate then stable? Are we talking 18, 19? I think we talked about this last time. I don't remember what that age was. Dr. Natividad, do you remember about what age? I know it's different with everybody. But
different with everybody. Usually young ladies hit their puberty and growth spurt somewhere around 11 or 12 years of age.
Okay.
Boys, 12 to 13 years. So we'll see growth plates fuse anywhere from age 14 to 15, maybe on up to 17 and 18 sometimes.
Okay, that's actually.
But as Dr. Bean was mentioning, a lot of times these injuries can be very unique, different than an adult's injuries because forces can propagate through that growth plate and be dispersed through that and then cause growth plate injury. When the force in an adult would actually cause a ligament tear, it can actually cause a growth plate injury in a child.
Okay, that's beautifully explained. And as an exercise physiologist, when you are dealing with young ones, and let's say anyone under the age of 14 or so, compared to, and maybe we can talk about, and Ryan, think of an injury, if we could, that may be, I don't know, that may be an injury that is comparable at the age of 30, but it really is affected by a growth plate situation when you're 12. Is there an injury like that that you can think of right off the top of your head?
Well, as for the specific to the growth plate, I can't say one that would come right up to the top of my head, but I can say there's a lot of applications with injuries within childhood that manifest themselves many years down the road.
Okay.
Even whether it's not directly related to the growth plate, for example, injury to the femur. Let's say a young individual breaks the femur bone. During the period of regrowth or rebuilding of that bone, one limb is growing while the other one is just trying to repair itself. There is a small difference in length distribution, and over years of time, and just that small difference in length with every step that one person takes, it's that level of impact of force, because one leg is shorter than the other, applies its effect on the knee and later than the hip, and then moves further up to the back, and then it moves its way up the chain.
And is there a way in the meantime, while that's happening, to either prevent the one that's not growing and to be able to have it grow a little through exercise, or is it just one of those things you just have to wait and see where things end up when they're 20, 30 years old?
Exercise plays an important key in the ongoing maintenance of a healthy joint.
Okay.
So if someone can apply exercise long-term, both rehabilitative exercises and maintenance exercises during the recovery period and post-recovery and lifelong, that's going to play the key process of maintaining a healthy joint, even if it's been compromised. Long-term, that's the key.
Long-term, and I like that long-term exercise. We're going to maybe say that 40 or 50 times today. Recommendations of preventing sports injuries, and I know we could be here for 18 hours talking about that. So maybe talk about the most common sports that are played in El Paso. Let's pick, the top 3 in El Paso, and how can we prevent some of those injuries, Dr. Natividad?
So I think probably the most common injuries occur with contact sports. And even a lot of ligament injuries are non-contact but high-velocity type sports, football, soccer, maybe basketball, and so forth. So when we're talking about adolescents, high school or even younger, there's definitely issues to look at all the way from pre-training when they're signing up for coming back from school, from vacation, and they're going to go straight into 2-a-days of football or what have you. If they've been deconditioned or haven't kept up during the year, then that can definitely impact their abilities. They can be dehydrated, they can have heat exhaustion. So one aspect of preventing that is making sure that they're staying fit throughout the year. And then another thing is not overtraining as well, and making sure that they have good flexibility, good cardiovascular endurance and strength. And it has to be all balanced, and Ryan can probably comment more on that, a balance between cardiovascular endurance, flexibility, and strength.
And on that note, what I'm going to do is skip Dr. Bings. I have a very specific question for you. But let's go to Ryan for a moment and talk about, as we are healing, as there is a time, and let's say that there is a torn meniscus and now it's repaired, but there's still some time. There's exercise physiology involved. There's time involved. And again, it's different with everyone. But what then happens with the exercising and the rehabilitation of a torn meniscus?
Related to the meniscus, are you asking about, you said time, are you asking how long does it take for?
I'm thinking about how long it takes, what goes into the exercising and the physiological portion of rehabilitating that area, and then about, is it several months, is it a year, is it until they can get back on, let's say it's a football field, until they can get back on the football field?
Sure. Starting from the onset, realistically, there are a few things that would happen. An athlete might start working with a physical therapist or perhaps a trainer there at the school, depending on which route that they take. An athlete may work with somebody else that's otherwise specialized, perhaps a surgeon, depending on what their choice is and what approach they want to, which direction, if they're going to go with surgery or if they don't. Altogether, everyone who's involved, whatever profession, whichever group of individuals will be part of that recovery process, together collectively they'll make decisions on what will be done. And they'll come up with a plan of action. And each individual will play their part. A surgeon will play his part, a trainer working with an athlete regularly at school will be doing their part. A therapist or a exercise physiologist will be doing his or her part, working with the athlete. And of course, the athlete has to do their part, right?
Exactly, yeah. And that's, I think, sometimes the hardest part. They know they're supposed to do it, but are they going to get out and do it? And that's why it's great to work with a physical therapist and an exercise physiologist to make them do it. Dr. Bean, I want to kind of change gears a little bit and talk about the population now that is done with high school, done with college, is living their normal lives, and now there's just issues that come along either from old sports injuries or from thinking, you know what, I haven't done anything in 3 months, but there's a pickup soccer game, and here we go. And somebody all of a sudden does something bad to their ankle. So there's reconstruction, there is repair, there is, and I'd love for you to talk about the most common thing that you have seen and the most common thing that you work on after the younger years. And I say that, let's say 30 and above.
Right. Well, certainly, I would say very common are a lot of knee maladies, either from old injuries, from meniscal injuries, ligament tears. That's very common, anterior cruciate ligament tears. The incidence of arthritis after that is quite high, in the neighborhood of 4 to 5 times the population. So, just that alone is worrisome in the early stages of an athlete that develops that type of injury. So, that certainly, just as you mentioned, you know, here lately I've had a bit of a rash of Achilles tendon ruptures, and you know, people in their middle age and try to go out and do just what you said, play basketball.
And that's a difficult thing to recover from, correct?
I
mean, Achilles tendon
it's
kind
pretty
of tricky.
tough.
Yeah.
You know, it's really kind of, I would say, overall, that I've seen that's kind of neat right now in orthopedics is there's a lot of things that are being innovative and tools that we can use that allow us to do a lot of things in somewhat of a minimally invasive way. And so, and actually for Achilles tendon, there is that equipment or technique that's used. And so,
so if you don't mind, describe to us what that is, or maybe do we have I don't think we do, but if we can describe what the Achilles tendon is, it's basically the tendon on the back of the heel.
That's correct.
But there's really nothing how is it adhered to the bone? And then when there's an issue, it's not like you can put a cast on. It's not like you can, how is that then repaired?
Well, a tendon by definition is an actuator of motion originating from a muscle going to a bone. So the Achilles tendon is part of the gastrosoleus complex, or the calf muscle, if you want to think of it.
We like the word calf muscle better. Muscle. Yes, much better.
And attaches to the calcaneus, or the heel bone, and through essentially a complex attachment of fibers and a base plate of cells that make that attachment strong. And certainly when we're younger, a lot of these tissues are more vascularized and I would say overall more flexible, which is a big factor in rupture. And as we get older, they get stiffer and less vascular, and that leads to the problems of rupture and then healing. So
what are some of the treatment options you are doing for the healing process? Is there a surgery or some kind of inserting something to keep things in place for a while?
Well, in the case of Achilles tendon, we can do a percutaneous type technique where we make a small incision at the rupture site and run a device up the tendon and down the tendon and past sutures and pull them out and then attach it to the calcaneus and do it through a small incision.
That's exactly what I'm talking about. That's what I want you to describe, because that's the stuff people are, well, how exactly is that done? Because we can talk about what it is, but until we describe how it's being healed. Because I remember I had a boyfriend when I was 18, and his Achilles, I remember them talking about it literally rolling up, and there was no way to fix it. And he was on crutches for probably half of a year. And I'm thinking, how can you not fix something like that? So here I am, 30 some odd years later, wondering how that would be different today. So when you're going in, it's non-invasive, I'd imagine, right? Because you're going in.
You have to make an incision and insert the instrument, and then basically you push the instrument up under the tissues and pass sutures through the muscle and then as you pull that out, they pull them out of the skin and down the muscle, and so then you can reattach the muscle that way in the specific technique. And you know, prior to that, we had to make a big long incision and suture it, and then there was a debate about whether you need to repair these, if you could just put them in a cast and plantar flex them. And they found that the re-rupture rate was higher and wasn't as acceptable a treatment. So, you know, generally we tend to be, I would say now, a little aggressive about doing that.
I think that's great too. And as the exercise physiologist, and let's use, because we're talking about the Achilles tendon right now, because we could talk specifically about so many things, how would you then, after this surgery, teach a person how to exercise, I'd imagine very gently at first, and then moving on? What is your role in that?
So it depends on how new they are to just getting back to the aspects of walking. Some people need to be taught how to safely negotiate things like steps, how to use their crutches if they're using crutches. Depends if they're using boots and they're not on crutches, how far along in the process they are. If they're beyond that and they've used a type of technique where they're not and they're beyond any of that, such as crutches and whatnot, you can use start using light movements and ranges of motion. Start using stretches. Move beyond that to pressure, using weights, and then using full body activities, and moving through ranges of motions that they haven't been using previously until eventually they can do more activities on their own.
And how important is it, and I want you to say it's very important, but how important is it to stick to the routine? And Dr. Natividad was talking about that too. It depends on the person, but sitting here today and people at home that may have been injured, that know that they've got physical therapy that they need to do and should be either physically going somewhere or doing it at home, I would love for you, and I see it on your face. You're like, oh man, if these people would just do it. So preach right now. Tell people at home.
You must. You have to. You have to. There's no question about it. You must do the work. And not only must you go for the rehabilitation, but that's not enough. That alone is not enough. You must go home and do the exercises that the specialist is showing you to do, and do them regularly. In fact, do them every day if that's appropriate. If that's appropriate with the injury that you have, to do them every day, and do them every day. And on the weekend, do them too.
Do them on the weekend too. You don't take days off for that kind of thing.
That's right.
I'd like to talk about, because we talk about sprains and we talk about strains. And a lot of people think they're interchangeable. A lot of people think they're the same. And I'm kind of throwing this to both of you, but since it's your turn to talk, Dr. Natividad, I'm going to ask you first. What is the difference between a muscle strain? And I guess that has something to do with it. It's muscles and then tendons and ligaments, and there's differentiations. But explain the difference between the two.
Yeah, a lot of times people use them interchangeably, and by definition, they're kind of not. You sprain, per se, a ligament. Ligaments hold bones together, bone to bone. So a sprained ankle is a ligamentous injury, or you sprain a ligament. A strain typically implies more of the muscle itself, the muscle belly, maybe the tendon. So we're talking about two different areas. Again, ligaments connect bone to bone. They're static stabilizers. They restrict motion and permit in certain planes of motion. And then muscles and tendons connect the bone to each other from a muscle to make an action onto a bone. And then those are typically a strain.
Okay. And here's the silly question. Often, people aren't going to go to see a doctor. It's like, oh, it's just a sprain, or oh, it's just a strain. For people, when is their treatment required, and maybe exercise required? And I guess that's the question too. Walking off the curb, walking your dog, and or, I was running after that soccer ball and I did something to my hamstring, but not sure what. Describe how it feels, perhaps, to someone who may be sitting on the couch right now, and what they should do about it, if there's a certain point where they should go see someone, etc.
Yeah, I think both probably, I'm sure Dr. Bean and myself have patients that come in and maybe they're days out or a week out and they've been hobbling and walking around on an ankle that's ballooned up and swollen. Typically, you might say in general, if it hurts significantly, to bear weight on it and it's not getting better over a couple of days, then I would definitely get an evaluation, by a medical professional, or go to the emergency room or urgent care where you can get some x-rays and see, one, is this to evaluate, is it a fracture, a bone fracture, a bone break?
Right.
And if that is negative, then two, you're looking at, is it a ligamentous tear or a sprain? And lastly, or is it a muscular type of sprain? So I think ice, elevation, some anti-inflammatories, and for a couple days, and if it doesn't get better, if it's getting worse or the same, then absolutely.
Go check it out. And on that note, Dr. Bean, what are they able to see? And if you could maybe describe what people are looking at with an x-ray. You can see bone very easily on an x-ray, but a sprain or a strain on an x-ray, how does one identify an issue there?
Well, and speaking about that type of soft tissue injury, we grade them generally from 1 to 4 based on severity, and so that has a factor in treatment also. And so x-rays, radiographically, we're looking at the osseous structures absent of really the soft tissue structures.
Right, yeah.
But there can be subtle hints of joint space widening, maybe in case of an ankle, the two bones of the ankle can be spread. That can be a subtle finding that needs to be operatively corrected. So generally speaking, if it seems pretty bad and it's swollen and it hurts, you probably need to come in and get an x-ray.
Check it out, exactly.
Because there are subtle injuries that can have a long-term effect.
And that's why I wanted to ask that question, because I think sometimes it's so hard to know if it wasn't a fracture, if that's ruled out, and it's like, okay, now what's going on? And I feel like that's 90% of all of us, right? It's we get hurt, we don't know exactly what's wrong. Why is my knee hurting? And it's been hurting for 3 months, and all of a sudden, not one day, but within a week, it's gone after those 3 months. And that's the big question. I'm starting to get all kinds of questions here from the audience. And one, and Dr. Bean, I know that you just talked, but this is specific to you, it has Dr. Bean's question on it.
Okay.
Can you talk about ankle replacements? And do you know anyone who does those in El Paso? Is there an ankle replacement? I know there's different portions with it. Maybe talk about the complex.
Okay, well,
ankle first.
I would have to say they're probably getting a little bit out of my field because I have to say I've never done an ankle replacement. But,
Goodness,
but
there's a lot of bones in there.
Right, and they haven't had the success that we've had in other joints, such as certainly the hip and the knee and shoulder, possibly because of the huge loads that are on the ankle, and you're putting in small components that are receiving large loads, and so that directly affects the how the implant wears, and so there just hasn't been a lot of success. Generally, lower demand patients can be candidates for that as long as the architecture of the joint is not too disturbed,
right,
or there's not a big ligamentous instability, for example. And so because of that, I would just say it's not very common.
I've never heard
doubt,
of it personally.
I doubt that there's been an ankle replacement done here. I would be surprised if there were 2 in 10 years. You know, and the foot and ankle guys, I just don't see that happening very much. Just communicating with them.
Yeah.
So more so if somebody's got a really degenerative joint and they're having ambulation problems, a joint fusion is done where essentially the bones are fused together and the joint's obliterated, which has not necessarily as good outcome, but if it makes you not hurt and walk better.
If it makes you not hurt and walk better, who doesn't want that? I'm going to come back to you and ask you about, and what do we have here? Just so, is this a knee?
Correct.
Okay. This guy's a hip.
Shoulder.
He's a shoulder. Okay, all right. And I was just saying, because there's the ankle, and I was thinking, how does one replay that? So do I remember you specializing in shoulders?
I do shoulder and knee reconstruction.
So why don't we pick up the shoulder, and I would love for you to explain, tell you what, if that's easier, I know we're mic'd up a little bit differently. And let's explain to the audience some of the most common shoulder injuries, where they happen, and what you guys need to do to help repair them.
Okay. So just, we'll look at this anatomically. This bone is the clavicle or the collarbone. This bone is the scapula or the shoulder blade. This is the humerus right here. And inside, which you really can't see here, but there's a socket. It's a very shallow socket, so we refer to it as a ball and socket joint, but it truly is very shallow. Some people might reference it, it's as if you're putting a golf ball on a tee. That's the amount of kind of coverage per se, or let's say stability that the shoulder has. So the shoulder is dependent on the ligamentous structures that hold it together, as well as the rotator cuff.
Okay.
So in getting to what are common injuries, we can have anything as simple as you may refer to in bursitis or an impingement. That's inflammation above the rotator cuff below the acromion in this area. And it hurts when people elevate their shoulder, it bangs on the undersurface, and it's just an inflammatory process in here. That can be treated with anti-inflammatories, corticosteroid injection, physical therapy.
And how would that injury occur?
Sometimes trauma, sometimes repetitive overuse injuries.
And one day it just starts aching. One day it just starts.
Correct.
Okay.
Another common injury in the shoulder would then be a rotator cuff tear. The rotator cuff is 4 tendons, 4 muscles that all come off the shoulder blade. They all come over and then insert onto the head of the humerus. So these offer a biomechanical force couple that helps elevate the shoulder. When there's a tear in the rotator cuff, as Dr. Bean had alluded earlier, tears in the rotator cuff are more common probably over the age of 40 when things start, breaking down a little bit. The tendon becomes a little tendinopathy or so forth.
You can say when we start getting old.
We
That's
all
okay.
start getting a little old.
Yeah, there you go.
And so out of those 4 tendons of the rotator cuff, the supraspinatus, this one in particular right here, is the one that most commonly gets torn, usually off the insertion here. And so if those are left alone and not addressed or found early, and then the biomechanics of the shoulder is thrown off. And that over time can lead to early degenerative changes in the shoulder and arthritis in the shoulder joint itself.
Okay. And when we're talking about shoulders, and I know that there are areas of the shoulders that are replaceable. And I don't know if we want to go to Dr. Bean now and talk a little bit about that. So let's talk about a tennis player that did great in high school and college and then kind of just did it as a hobby from there. And now he's 60, in great shape, fantastic. But he needs something replaced in his shoulder. And what might that be with common injuries and just wear and tear and, frankly, just getting older? What might it be that he would need at this point if there's a portion that needs to be replaced?
I would have to counsel him that if he's that high level and playing, we've tried to do everything possible to avoid a joint replacement. There can be some resurfacing, some smaller procedures.
I like the conservatism. I like that. Yeah.
And of course, certainly the proper exercise physiology. Keeping the what muscles he's got, toned and flexible for the shoulder. I would probably do that if he's reaches a point where there's just too much discomfort. And if the systems of the ligament muscle systems are intact and you're going to consider a replacement, I would have to counsel him to tone it down a bit and maybe not hit the hard overhands.
Just tone it down a bit. I like that. Question here from the audience, completely separate from the shoulder. You can either keep it as a friend on your lap or put him back or do whatever you want to do with him. I'm going to throw this actually Ryan's way, but if you need to shoot it back to one of the doctors, that's fine. But questions here from the audience. I want to respect them as much as possible. And I will give this disclaimer, this is as much information as we have. So sometimes we do the best at diagnosing and answering as we can, but that's why we have that disclaimer saying, hey, we're going to do what we can. What causes shooting pains in the arms besides an injury? So this is maybe aging. And the reason I'm asking Ryan is that I'd imagine with people coming to you and they've got issues, they've got pains, you're trying to stretch and work things out. The pain is independent of movement. So I don't know what that may be. And again, this is all that we have. If we can't answer it, we can't answer it. But I thought that maybe we'd give a shot at it.
It'd be unfair to try to answer that without being able to ask more questions.
Right.
I mean, all of us here would love to ask more questions and tell me more about it and when do you feel it? How often have you felt it? And when did it start? And
good question, yeah. And I'm going to say, maybe I'm going to expand on this. About a year ago, myself, I was getting shooting pains into my shoulder and into my arm. I didn't do anything. I woke up one day and it was just like, man, I can't. Reaching for the seatbelt. Reaching for the seatbelt, I couldn't do it. Reaching on top of my steering wheel, I couldn't do it. I don't know why. I did go to physical therapy. It didn't help. Sorry. About 3 months later, which is why I used that later, it was like, okay, little by little, in about 2 or 3 days, it was gone. It lasted 3, almost 4 months, and then it disappeared. I'm just throwing that out to everyone else who may have a situation like that with a knee, a shoulder, an elbow. What could that be? And maybe I'll look at Dr. Bean, because I think that you're the guy that years and years later things creep up. So my biggest sport was swimming, which I think is pretty benign, and gymnastics. So I did a lot of jarring in gymnastics. So maybe that's something that was an old injury there. But best guesses?
Well, I think, again, overall, as we age, our bodies are continually transforming through our life. They're not static structures, even the osseous structures. And so there is definitely, with aging, loss of flexibility in tissues. That's probably a big factor, and also a loss of strength in muscle tissue. So we age and we have all those symptoms for a reason. And I think that there's a certain amount of discomfort that comes through the nervous system as well.
And the nervous system is something we haven't really touched base on, but that's so important in the pinching of nerves or them just getting in the way. So I'm glad that you're bringing that up.
Well, I mean, there's so many people come in and say they have a pinched nerve, and we can test them and don't find a pinched nerve on electrophysiologic testing, but that doesn't mean necessarily they're not having nerve pain. I think that there certainly is referred pain from certain body parts to other body parts, and can be a factor in the discomfort. And
see, and that's fascinating to me. How does one know if you're a layman, and this is not what you do as an area of expertise person all day, every day, and you are feeling, and I feel like nerve pain is somewhat specific. It's very different than muscle pain or bone-on-bone pain, or I feel like it's like, oh, that's a nerve pain, and I have that in my neck. How is one to differentiate that? I guess I don't know if that's a question so much as when do you go to the doctor and find out what it is? I guess when it bothers you enough. Would that be the right answer? I don't know.
Yes, I would probably say so. And if it's associated with other symptoms like development of a mass, or
that's a big thing.
Bleeding from some place. I mean, other symptoms can be a factor in creating the alarm and what you need to do. But I think I think everybody that's gone through the aging process has realized that there's lots of it's painful.
Yeah, it is. It's painful.
I'll just comment on that.
Yes, please, Dr.
It is a
Patavidi.
challenge. Upper extremity or arm pain, shooting pain down the arm can be a challenge. And I think starting down, looking down the chain, it can either be coming from the neck, from the shoulder, elbow, or wrist. And in general, people, if they have a sharp lancing shooting pain that comes from the neck all the way down to the hand and the fingers, typically we usually find a cervical spine and neck situation, a herniated disc, a compression on the nerves. The shoulder, if it's impingement, if it's a rotator cuff injury, that can also cause pain up to the neck. And it can cause pain down the arm, but typically not beyond the elbow.
Right.
Usually not beyond that. So shoulder entities will go about to the level of the elbow. Elbow, golfer's elbow or tennis elbow can also cause pain down to the hand, but won't usually cause pain up. So yes, there's multiple ways for us to look at it, but it can be challenging to really kind of diagnose these.
Yeah, and it's one of those things too that we try to exercise it and move it around as much as possible. You hit on something too that I have a laundry list, and I think we did this last time you were on the show because I had this from the last show, but we were talking about stress fractures. We talked a little bit about that, we haven't talked about dislocated shoulders. And I'm thinking about movies where you see somebody's shoulder got dislocated in a football and the doctor comes in and puts it right back together. How does that work? So bring that one on. Since we were just talking about shoulders, dislocated shoulders, I'm thinking football. And are you able just to put it back in place and everything's fine? Or does Ryan come in and do some work with this guy that dislocated his shoulder and there's some stuff going on in there for the next couple of weeks?
Right. That's a good question. So dislocation of the shoulder, because as we mentioned earlier, it's a ball and socket, but a very shallow socket. So people that are hypermobile, have loose ligamentous tissue, can be at risk for that. Trauma, definitely. Football, wrestling, just traumatic falls can cause that. There's definitely been studies that have shown in adolescents or young adults, when a dislocation occurs younger than about the age of 20, they're more apt to have a recurrent dislocation. So those are individuals that typically, I may still try conservative treatment, physical therapy. I usually do that anyways. But if somebody comes to me with a history of more than two or more dislocations, then and an MRI confirms that they've torn the ligamentous structures of the labrum of the shoulder, then a surgical repair arthroscopically is the best way to treat that. And as we were mentioning earlier, we have innovations to be able to do, this used to be done open. We can now do labral and shoulder stability surgery arthroscopically with very small incisions.
And that's actually, because I just got the 20-minute mark, because that's something I really wanted to get into this evening as well. So what I'm going to do right now, so 20 minutes means we have about 18 minutes. I'm going to stop these questions. I'm going to go to you three because I do want to talk about new stuff that's happening on the horizon in your areas, which there's a lot. So is there anything yet, and I know there's a lot, but is there anything you wanted to get across specifically tonight? And actually, Ryan, I'll start with you because I feel like we just talked to Dr. Natividad here. Is there anything that you wanted to talk about or get across to the audience that we may not have touched base on yet tonight, or something that we may have touched base on but you want to expand on?
I think as the discussion goes on, that might come clear.
Okay.
And we'll probably get to that.
We'll get to that?
Yeah.
All right. Dr. Bean, anything that we haven't talked about yet that you want to get across?
Well, again, to me, the neatest thing that what I do and what we do as surgeons is just the innovation that just continues to occur. You know, we're doing harder things now through smaller incisions and you know, endoscopic work, and it's just it's really remarkable from when I started my career.
Nicely said, Dr. Natividad, because I'm going to get specific about this in a second. How about you?
Yeah, I agree. I think one of the most unique things about orthopedics is that it's continuously advancing and evolving with more unique and advanced surgical techniques. We're doing things more minimally invasive. We have more armamentarium to be able to use different devices that previous procedures that were done open with large incisions, we can do arthroscopically through a scope. From a rotator cuff tear to a labral repair in the shoulder arthroscopically, to ligamentous reconstructions in the knee arthroscopically. So I think there's been a lot of advances, and there's other things that are happening in our profession, from biologics, meaning maybe stem cells, and the data on that's very early. We get a lot of patients inquiring about that. There's not really a lot of great studies long term, but there's definitely things in the future that will probably help.
And I look forward to doing this show 5 years from now and seeing what is new. And I was talking to Dr. Bean, we had a doctor on several years ago, and he was talking about just how cartilage, you know, just the way that cartilage can become more cartilage within your, you know, if there's something going on with the knee, there's injections now, and we haven't talked at all about injections. And I don't know if that's something you do want to talk about, because that's relatively new. I'd say within the last decade new. Dr. Bean, you're nodding your head, so you get that one.
Okay.
Talk about the cartilage injections for people who have knee issues, and again, we're talking about knees and hips and bone on bone and the pain that causes.
Right.
And just the idea of cartilage injections.
Well, specifically, we're to talk about the knee. I mean, there's different injections that we'll do. Oftentimes, you know, the long heralded treatment is a cortisone injection.
Right.
Patients come in, their knees inflamed and painful. It's a kind of a quick, easy way that we can ease pain and sometimes improve the rehab of a patient. So it's tried and true, but it's not long lasting.
Right.
And then there was the development of what's called viscosupplementation, and
That's what I'm talking about.
These
Okay.
were large changed molecules of protein and sugars that reproduce the mechanics of joint fluid and basically a lubrication type application. and found that they could have some reduction of discomfort that way. As that technology has gone along, actually, a lot of the studies have shown that it's not as helpful in relieving symptoms and really to warrant the cost of it, because it is quite expensive.
So there were high hopes in the beginning,
yes.
and it's not working out to be
So
that case.
our academy backed off on really saying that it had a lot of success. So a lot of insurers don't even cover it now, and so and then with the stem cells and embryonic cells, that I think that's just right now too early to know.
Yeah.
And you're talking, those are real expensive therapy, and there just hasn't been enough data to support a great success.
Right. And that's why it is so interesting, too, to have this show year after year, because there's like one extra thing. And like I was talking about, when the idea of these cartilage injections, that's for one reason, that's how I have them in my head. I thought, man, that would be fantastic. But again, it takes a little while. It's an experiment. It's always a process, and figuring out how it goes. I have a ton of questions here from the audience, and since we are looking not tight on time, but tight enough, I'm going to just start shooting out questions, and I'm going to, if I look at one of you specifically, it's you, and let's answer them as quickly as we can. This one I'm reading cold. A 71-year-old woman uses a cane to walk and needs to get both her right and shoulder knee replaced. So in this, her question is, which one should she do first? And I think that's a good question. Again, we don't know a lot. We don't know which one's worse or not, but maybe let's talk about healing. You're nodding your head, Dr. Bean, so you get that one, because this is your population anyway,
yes,
of people
right.
you said you. So she needs both shoulder and knee replaced. What do you suggest she does first?
I would probably advise her to get her knee replaced first, just so she's not loading a new shoulder joint, which probably is going to be an extended period of time of recovery for that. And generally, her locomotion is probably more important than her shoulder function anyway.
Right.
So generally speaking, I would go after the knee first, and then once that's accomplished, she might change her mind.
And say, Dr. Bean said. Ryan, this one I'm going to give to you, and this is just a quick question, and you can answer it 50 different ways and still be right. Is running bad for the knees? Question for the audience. Take it any way you want.
Yes, and and relative to other exercises, there's so much more benefits with reduced risk of injury that can be utilized with other forms of exercise.
Such
as walking with brisk walking, or walking with uphill. You can get excellent cardiovascular benefit with a much greater reduction in risk of injury.
And I like that too, and often we'll just say a good way to make your health a little bit better is to get a dog, because at 5:30 or 6 o'clock or 7 or 8 o'clock, they're going to want you to take him for a walk, him or her. So that's always good. It's not a question, it's a comment from the audience from a question earlier. The person that called earlier and we said we don't have enough information on them, I just want to give them a kudos for continuing to watch. The tendinitis and shooting pain caller said that 71 years old, and she was on the national swim team but hasn't swam in 35 years. But congratulations for being on the national swim team, and thanks for calling back. And I hope that we answered your question as good as we could at that time. Dr. Natividad, your name is on here. What is the recovery process after a child has had a cast or a boot removed? Again, not a lot of information, but in general, what could be an answer for that?
Well, if we're looking at a sprain, like a ligamentous ankle sprain, I'll typically do that with a cast, or rather with a fracture boot and crutches for 1 to 3 weeks, depending on how severe it is, mild, moderate, severe. If it's a fracture, then all fractures take a solid 6 weeks to heal. And as we age in our population, that may take more like 8 weeks or 10 weeks, depending if somebody's very fragile. So though children tend to heal even faster, so that could be as short as 4 weeks. It would really have to be followed, if it is a fracture, by radiographs.
Okay, as short as 4 weeks. Man, to be young again. Question here from the audience, Dr. Bean, I'm giving this one to you, 13-year-old. Can an operation on the foot, again, it doesn't say what type of operation, but an operation on the foot of a 13-year-old from a sports injury have any long-term effects? And maybe, again, it's vague, but maybe we can go back to growth plates, but this is the foot. Does the foot really come along in that idea? Because I think growth plates as the femur, as we talked about the long bones, but in general.
Sure. There's growth plates in the phalanges and the long bones of the foot, the metatarsals, and so, yeah, that's a consideration. I guess, again, that's a broad question. The question is this trauma something that needs to be done, or is this elective procedure that potentially maybe could wait?
And it says it's from a sports injury. So, and on that note, I will throw the same question over now that we've answered the medical portion of it. Now, as the operation on the foot, the exercising and the rehab from that, what might you be able to add to that?
If it's a 13-year-old individual and they have had either just a trauma or it's an elective surgery, they're 13, I'm sure they'll do just fine going through the therapy and doing well with the recovery process. So
as long as they do it, right?
As long as they do it. They're young to do well and recover fast. So
Nice.
if they do their homework, they'll be fine.
They do their homework. That's the hardest thing, I'm telling you. I have a 15-year-old and then a 21-year-old. Question here from the audience. I'm reading this cold too. Is there anything that can be done for chronic pain caused by a 30-year-old rotator cuff injury? The caller is now 72 years old with 2 surgeries to the shoulder. And the most recent surgery was about 20 years ago. That's Dr. Bean. So, again, as much information as we have on here, is there anything that she can do for chronic pain? She's already had 2 surgeries. The most recent one was 20 years ago, 72 now. What would you say to this person?
Well, certainly, some degree, possibly, from a non-surgical standpoint, which you want to try first, of course, is trying to maybe modify activities or certain household aids. Maybe you don't have to reach as high or whatever, but generally that's implying, I assume, that she's had some rotator cuff surgery that maybe hasn't been all the way successful, and even if it's completely failed, it doesn't necessarily mean surgery needs to be accomplished. There are 4 muscles of the rotator cuff, and so rarely are all of them torn. So conditioning what's remaining can be a big factor in helping to reduce symptoms. And so certainly conditioning the muscle and exercising, so some degree of physical therapy, anti-inflammatory, maybe occasional cortisone shot if it flares up. But certainly if that progresses to a point where life is miserable and can't do anything, and the joint begins to wear, where the articular cartilage is wearing in the joint. Before, we couldn't really reconstruct that with a primary total shoulder arthroplasty without a functioning cuff, but we do have implants now that are pretty successful, not as good as a primary, but it's a type of replacement shoulder that's designed for that degenerative shoulder with a big cuff deficit.
Yeah. I have a couple of questions here from the audience still, but I wanted to, actually I'm going to continue taking these. We have about 4.5 minutes, and I'm going to talk about tendinitis in the shoulder and just what can cause it aside from trauma is a question from the audience. And I know that we're talking about sports injuries and injuries in general, but tendinitis in the shoulders besides trauma, Dr. Natividad, I'm going to give that one to you. And then I've got a couple of easy questions after that.
So tendinitis in the shoulder can be caused, aside from trauma, from a lot of times repetitive overuse injuries.
Okay.
This could be not only an athlete, but it could be just a manual laborer. It could be somebody who does something even repetitive and in a clerical manner. So that tendinitis or bursitis, as we were looking at the model earlier, can be treated with a spectrum of things from anti-inflammatories to a cortisone injection to physical therapy. And if those things fail, then an MRI would be appropriate to evaluate, is there potentially a rotator cuff tear? And if there is, then that takes us usually down a different path, probably a surgical repair.
Okay, and that is a complete different thing. What I do love about this show so far is that We haven't really talked about drugs, and I like that very much. We talked about anti-inflammatories, maybe a cortisone shot here and there, because we're talking about chronic pain, and this is painful stuff. And I like very much that we're looking at treating the core issues versus just popping the pills. So thank you for that. I do want to mention again that if you are a Facebook person at all, that we are live on Facebook right now, but I know that if you look up KCOS TV in the next several hours, even the next several days, you'll be able to watch this as well. Question from the audience, because we have ads, we see this in magazines, and it's fish oil pills. I hear this often when it comes to cardiology. I don't hear about this often when it comes to bones and tendons and muscles. So a question from the audience. Anyone want to take that one? Dr. Bean, you need to stop smiling because I'm going to throw everything your way. Dr. Bean, you're chuckling and smiling, so you get that one.
Well,
and or supplements,
right,
since we're on that subject.
Well, absolutely. I mean, basically, all the tissues of our body with good nutrition can flourish and maybe counter some of the aging factors. And so we know the fats that are in fish oil are good fats and healthy, and so they reduce a lot of things that are plaque formation and things that are bad for the cardiovascular system. I think that implies, good vascularity as well to the tissues, and so I don't think there's necessarily a direct effect that I'm aware of fish oils that has an effect on muscular tissue, but I'm sure it's nutritional and.
And Ryan, I feel like that's where you need to pipe in really quick and say, you're the exercise physiologist, right? So aside from the exercise, homework with eating right and doing what would you say to the audience?
So it's essential that we have at the foundation of a healthy diet, and no supplement that we take can take the place of a healthy diet. But supplements are important to add in because we can't always get what we need from the foods that we consume. And diet, exercise, and adequate nutrition, those are key factors.
Agreed. So eat your Wheaties, as they would say back in the old days. I'm showing my age. Who are you talking to over there? You're counting somebody down? You're wife. Totally oh, really? Really?
My wife's here.
Where's the wife? Hi, honey. How are you? You should come say hi to everybody on the air. I love that your wife's here. I dig it. I wanted to say again, thank you so much for watching us this evening. We have this show on kcostv.org. Go to programs and find the show. We also have it on epcms.com, and you can watch the show again. Facebook, YouTube, there's all kinds of places, because I know that sometimes we feel like we're rushing through this show, and we appreciate you watching. I'm Catherine Berg. Good night.